the midwifery model of care should be accessible to everyone. There's just this cultural belief that you have to go somewhere to have a baby, and it's a pathological thing that's happening. You must go be saved by a doctor. What is this place? And who are you? And what do you have? Where's the magic crystal? Your water is most likely not gonna break in Walmart in a huge gush, and the baby is not then gonna fall out in the car on the way to the hospital. Like, TV birth is not real birth. I think people birth best when they're left uninhibited to just listen to their instincts and they have the freedom of movement. I would never do that as a human being. So where did that become okay in a provider's educational journey? Where did it become okay to check someone's cervix, to put your hand in someone's vagina without their consent? No comments. Just don't make comments about people's birth choices or bodies or whatever. Just provide non-judgmental care. The midwifery model of care is just different.
Let's start.
Okay.
Okay, I'm ready for the question.
I'm ready, yes.
First, wanted to ask you about the story of this birth center.
Yeah. Yes. Okay. So Roots Community Birth Center has been here for about 8 years, and it was founded by Rebecca Polston, who is a certified professional midwife and a licensed midwife. And she has a previous career as a community organizer. So that's where her kind of background and her framework for how she approaches life comes from. She worked as a certified professional midwife, as a home birth midwife with Allie Folene in a home birth practice for a number of years. And not to tell Rebecca's story completely for her, but essentially what she found is she was not taking care of families that looked like her. She was taking care of wealthier white families who had access to private home birth in the US, which in the US, home birth is not covered by insurance, state insurance, or commercial insurance anywhere. Perhaps here and there with a certified nurse midwife, but certainly not with certified professional midwives who do the vast majority of home births in the US. So Rebecca, was certainly enjoying the family she was taking care of, but it was not her community. She is a Black woman, and she was not taking care of women of color due to a number of things, primarily financial privilege. So she opened Roots with the intention that the midwifery model of care should be accessible to everyone. Folks who are on state insurance, who are of a lower income, et cetera, should be able to access midwifery care, because we know midwifery care results in good outcomes, and we know that the US maternal health care is not good. Black women are 4 times more likely to die in childbirth or in the postpartum than their white counterparts. So her intention in opening the birth center was to create access for women and families of color, people of color, to access midwifery care. So we've been here for about 8 years doing that. It's expanded and shifted and all those things in 8 years. And we now have a 4 midwife team, so Rebecca, myself, and then Willa, our certified nurse midwife, and Mandy, another certified professional midwife, as well as some support staff and a family nurse practitioner. So that's Roots in a very little nutshell. Roots Community Birth Center and Family Wellness is a freestanding birth center. We're accredited by the American Birth Center Accreditation Committee, also called the AABC, or I said that wrong. It's the Commission of Accreditation from Birth Centers. There it is. I never say their name correctly. So we've been here for about 8 years. Rebecca Polston is the owner, and she opened it. We're a team right now of 4 midwives, 3 certified professional midwives and 1 certified nurse midwife, and 1 family nurse practitioner. So people come to us for prenatal care, postpartum care, labor, birth, breastfeeding, newborn care, and pediatric care. So it's busy. But this is the waiting room. We've got some supplements and things out and about, and our boards with all of the names. What else do I know? There's Miran. Oh, there's so many.
What do you do when the boards are finished?
We're just keeping them forever. As we go, you'll see like back to 2015, and just the board size has changed from 2015 is so small, and we've expanded. But this is a cozy waiting space and like the breast pumps and all that jazz that folks can get through insurance. And then a bunch of babies. This one here, let's do this one. This is the family medicine room. So this is where we see the kiddos, which I think is new from when Anna was here last. So we've got like the toys and some books for them. But this is where our family nurse practitioner sees folks of all ages, but mostly pediatric patients right now. And then our certified nurse midwife does a fair amount of like pap smears and IUD placements and gynecological things in here. This room over here is kind of a waiting room, kind of an exam room, can be used as a third birth room. We didn't. It was carpeted. It was a classroom, sort of.
What do you do here?
We do some visits when families bring multiple kids and just need space to spread out. We do that in here. And in the rare event that we're having 3 babies at once, we can turn this into a birth room.
Oh, okay.
So we would take the room divider out and put up an inflatable tub and have a baby.
What's your favorite book?
For pregnancy, I really like Birthing from Within.
Ah, really?
Yeah.
I was a student there.
Were you?
I'm certified to person.
Oh, I love that one.
Where is the book?
I don't think we have it. It's probably loaned out because I like it so much.
Yeah.
And I like Mindful Birthing. That one is good. This is Rebecca, the owner, and a very fresh, sweet baby with his little water-washed head. Yeah.
How many births do you have per month?
Per month, we'll take up to 20.
Up to 20
Up
per
to
month?
20. We don't.
Wow.
Excuse me. We don't normally hit that, but we expect some folks to transfer for medical reasons, or like they move to a different state. So then the goal is 15 in the center a month, but it varies. That's my baby. Fun fact.
Oh.
That's Norsola.
What's her name? Sorry?
Norsola.
Norsola. Wow, it's beautiful.
Thank you. She really likes to swim, so there she is.
It's from Florida?
It is in Florida. We were visiting my in-laws.
How your birth center is being organized? I mean, when a pregnant woman is coming to the birth center, what should she do?
Folks tend to find us through word of mouth or through the internet or social media, and then if someone wants to come to Roots, they should just call the front desk, or there's like a link on our website to click and like book an appointment. But they just book their first prenatal. It doesn't really matter if they've had care elsewhere or not. We're happy to sort of just meet them where they're at, assuming they're in like essentially the first half of their pregnancy. And then at the front desk, I'll get them scheduled. They'll have an hour-long intake appointment with the midwife, do labs here. We do all of our labs in-house. And we order out for the ultrasound, so they would get those at an outside facility. And then they just keep coming on sort of that normal maternity care schedule of like every 4 weeks until you're 28 weeks, every 2 weeks after that, and then weekly in that final month. And then we, we see them in labor and birth, of course. They come here to us and birth at the birth center. The on-call midwife's always available for whomever calls and needs something. And then postpartum care at Roots is something that we do really highly value. So we see people in their homes in the first week postpartum. We'd rather they not get back in their cars in cold Minnesotan weather to, haul their newborn over here. So we see them at day 1, day 3, and day 7 in their home, and then again in the office at 2 weeks, 4 weeks, and 6 weeks. And those appointments are for both the parent and the baby. So lots of lactation support and mental health support. We don't have like a therapist or a counseling situation, but we have built that rapport. We have built a relationship over the course of the pregnancy, and our postpartum visits are an hour long. So we can do just a lot of midwifery counseling. It's not the same as a mental health therapist, but there is a lot of how are you? How are things going? Are you sleeping? Talking about strategies around postpartum support. And then our nurse practitioner and our certified nurse midwife are both prescribers, so they can prescribe medications if someone's interested in mental health medication on a low level. If there's some severe mental health issue, that's something a psychiatrist should be involved in. But
I talked to several women here in Minnesota, by the way, and I asked them, they were given birth in birth centers and sometimes in hospitals, and I asked them about the mental health issues, how they're being discovered if something is not well. And they said that they were at the postpartum visit after 6 weeks, I think, or something like this, at doctors, and yes, they were asked with having this questionnaire for postpartum depression, but they lied in this questionnaire because they didn't want to be sent to the psychiatrist they don't choose, and they didn't have the opportunity to choose the psychiatrist or psychotherapist they want because of the money and the insurance coverage. And I was surprised that it doesn't work, so these questionnaires on postpartum visit, they don't work. How do you make these mental health issues or appointment really work?
I think you have to have a trusting relationship with someone. And you have to know someone. Like if I've been taking care of someone since they're 8 weeks pregnant, I've seen them monthly, I've seen them every 2 weeks, I've seen them give birth. They know me and I know them, and I can Some people mask really well, and they hide if they're not well, but building that trusting relationship where they know they can come to us and they can say, I am not okay. And they know we will get them help that works for them. We're not just gonna be like, standard medication, standard therapist, off you go. We're gonna be like, okay, you, specific person in front of me, what do you need for your mental health? Here are the resources I know of. Here's what you're saying you think will work. Let's combine these and find the whole picture that works for you. I think people they know the routine screenings. They know what the questionnaire is asking for. It's like, are you depressed? And depression comes with avoidance, and it comes with shame and fear, and people aren't necessarily going to say yes to that, especially when you're taking care of a population that's really used to being marginalized, used to being historically mistreated by the medical system. They're not going to invite in more medical system. And a lot of postpartum families are afraid if they say, yes, I'm depressed, I need help, that there'll be CPS involvement, child protective services. And so having that trusting relationship allows people to feel safe in saying I need help without fear of shame or retribution of some kind. So.
Tell me more about your clients. Who are they? You said that you have people who are marginalized, so you have a Black community. Who else are your clients? I mean,
65%, let me see if I can say it correctly. Yes, 65% of our clients are on Medicaid, so folks who are making less money. And then 75% of our clients, one or both parents, identify as a person of color. And we also care for a lot of LGBTQ folks. So families who don't find themselves fitting well in the standard medical system come here, and we're happy to care for them. We're happy to care for anyone, of any body and so on, but that's the bulk of our clients. We're also the only birth center in Minneapolis that doesn't have a BMI cutoff.
What is BMI?
Body mass index. So restricting who can give birth in a birth center based on their weight.
How did you get this?
This is a ridiculous thing. Where did it come from? The American Academy of Obstetricians, perhaps? I don't even know where it originated, but...
Yeah, but how did you get this permission to...
We just said we weren't going to listen to that rule because it's not evidence-based.
Wow.
So we just said no. It is a bit of an arguing point every 3 years when we reaccredit the birth center, but BMI has not been found to actually have a direct influence or causation on health outcomes. So being of a larger size does not necessarily mean someone is unhealthy. It just means that their body is larger. It doesn't mean that they automatically are unsafe to have a baby come out of their body, and we understand that and respect that. So we're happy to care for folks who fit our risk criteria that we're required to stick by, which is one single baby who's pointed head down, who's born at full term, no medication managed diabetes, and no hypertension. If you also have a high BMI, it's fine. These are the 5 things we can't have. A high BMI, it's fine.
So just the 5 restrictions.
There's a few other little nuanced things that get a little more specific, like, anemia, severe anemia, an active STI infection, like HIV or syphilis or something like that. But BMI, we are fine with because it's not actually a true indicator of health. We can go upstairs to the birth suites and then out to the yoga space. So this is our little courtyard.
But you didn't have it last time, some years before.
I don't know what was going on here last time. It has had a few iterations. Now it's like offices and then yoga space. So it's definitely improved in its existence.
You're growing.
Yes, we're growing a lot. We're actually outgrowing the building and working on a new building.
Not here.
Just across the street, actually.
So you're going to have several buildings.
Yeah, that's the goal.
Okay.
But come on up. I think some staff might be eating lunch, but this is the way to get to the birth suites. So, once we come up here, the first room we come to is our secondary birth suite. Let me turn a light on. This room would get used if 2 people were laboring at once, which doesn't happen that often. We do, cap the number of births we take per month for a reason. We like to be able to focus on one person at a time when it's possible. But yeah, here's this room. And we would put this inflatable tub right here. So every room.
Enough space here?
Yeah, it's a little cozy, but it does work. And then in all the drawers is all the medical supplies just tucked away. And not staring at anyone in the face.
It's very cozy.
It is cozy. We call it the pink room.
Oh, okay.
Yeah.
And here you then.
Our little baby announcement board. Those stairs always get me out of breath. I gave birth at home. No, I gave birth at home, but Rebecca was actually there. So that was very sweet. And then here's our sort of main birth room, which has been painted since Anna was here. Yeah. Over here.
And there by the tub.
Yeah. That's so
in
sweet.
The tub with Miran. In the tub, and then I have to go out. His head got out in the water, and then I have to.
His shoulders were a little sticky.
Yeah,
Oh, I know.
Shoulder
I think so. I wasn't there. Did you have a shoulder dystocia with Miriam?
He's stuck
Yeah.
inside with
Shoulder
his
distance.
Yeah. Yeah.
And
Oh.
Jackson helped me to.
Twist a little. Yeah. Oh, your babies. That's so sweet.
I mean, I don't know. What do you feel? I feel like my heart is like beating like a lot.
Do you feel like you're remembering your birth in your body right now?
Mhm.
Yeah. What does that feel like?
Warm.
Warm.
Really, really warm.
Oh, that's so sweet.
I'm really connected to this place.
Yeah.
It's just something special for me.
I'm glad it's a warm memory.
Yeah.
It's very sweet. Yeah, we try to keep all of the medical gear tucked away so there's no machines beeping at you and there's no bright
How
light.
do you do the CTG or what do you use for listening for the baby?
For baby, we use the handheld Doppler.
Okay.
So this, and we listen. It's called intermittent auscultation, which means to listen periodically. So about every 30 minutes in active labor, and then every 15 when pushing. More often if something's concerning. But yeah, there's our little Doppler friend.
As well?
Yes, until you get to this part. So you can put the whole cord in the water, but don't put this part in.
Okay.
Yes. Something we all joke about. Don't drop the Doppler in the tub. This is all of our newborn gear. So we've got baby blankets, newborn stethoscope, an ambu bag in case a baby needs some help breathing, a pulse oximeter. This is a DeLee suction, just a different type of suction. And this is a bulb syringe also for suction. And then we do have everything we need if we need to place a different airway. So this is LMA, which is for an extensive resuscitation, which is not something we do frequently, which is fortunately. But we have all of that just in case.
How often do you need emergency stuff?
That's
How
a good
often do you use the ambu?
ambu bag. Maybe 1 in 6 births, 1 in 5, just for like a couple breaths, just to kind of. Sometimes babies are stunned if they come flying quickly into the world. In terms of doing like a full resuscitation involving chest compressions, I've been a midwife for 7 years and I've actually never done chest compressions, so that we don't get to that extent very often, which is great. And then there's just some other odds and ends in here, like tape measures and newborn diapers and little baby care items.
Is it a jacuzzi?
It is not, there's no jets because those are harder to clean if multiple people use them. So no jets, but it is very cozy and comfortable. So I'm told. I've never been in this tub in a bathtub-esque way, but.
And the shower.
The shower is nice in labor too, and there's lots of space to do lots of different positions in there if someone wanted to squat or sit or stand or lunge or whatever they came up with. So I've had a few people lay on the floor in there, and if that feels comfortable in labor, then by all means. So yeah, I gave birth like hands and knees, like on a pile of pillows on a bed. Yeah, and that worked well for
Why
me.
did you choose to give birth at home, not here in the center?
I thought if I was working here, I worked until my due date. I think if I couldn't have a home birth, I would have birthed here, as opposed to birthing in the hospital. That would have been my preference. But I thought I would have a hard time getting out of my work brain here. I figured I would be telling people what to do too much, which I don't know that I didn't do that at home. I certainly told people what to do a bit in my own home, but I still really love my home birth midwife. Her name's Allie. And I thought I wanted my dog there. I wound up kicking him out, but I wanted to be at home. I was a home birth midwife before I worked here, so.
So your midwife is not from here?
No. My midwife is Allie Foline. She's at North Star Midwifery. She had a partnership with Rebecca, who owns Roots, for many years prior to Rebecca opening Roots. So Rebecca did wind up coming. which I always tease her. She walked in when I was in transition, which I didn't really know I was in transition, but I was. And she came in with like 2 trays of Starbucks for everyone because it was like 9 in the morning or something. And there was no Starbucks for me, which is fine. But she came in and I just immediately was like, this is terrible. Why do you have 3 kids? She was like, oh, we're at that part. Okay, lovely. And then we had a baby, so it was fine. But yeah, home was definitely the right spot for me. I was very comfy there. But I would have been happy here. I just would have been very bossy. There's nothing. Yeah, yeah, somewhat. Yeah, I try.
Let's talk about money then.
Oh yeah.
Because you said that your clients are mostly with low-income families and people of color, mostly, the majority of them. So how much does it cost, the care in your center?
Yeah, insurance does cover the care. State insurance pays very poorly. I don't know how much you know about maternity care billing in the US, but it's billed as, so someone's prenatal through postpartum care, including their birth, is billed as a global package, which is called the global maternity fee. And the date of service for that fee is the date that the baby comes out. So all of that prenatal care is provided before the baby comes out, of course, and it can't be paid until the baby's on the outside. So that's an interesting like budget to function with, of caring for people and paying staff and keeping the lights on prior to a baby coming out and us making any money. And then commercial insurance pays all right for birth, but state insurance, which is 65% of our clients, pays very poorly. Minnesota health insurance pays about $1,200 to $1,600 in total for the entire year of care, prenatal care, labor, birth, newborn care, postpartum, which is kind of abysmal. $1,200 for the whole thing doesn't go very far. And if the client transfers, we don't see any of that money if someone transfers in labor, because it goes to the place that the baby actually was born at. So if someone decides they need pain management, if they develop a complication and need to go to the hospital, that kind of a thing, insurance pays the place that the baby was born, which is bizarre because they didn't do all of the care.
Okay. And if a woman doesn't have an insurance and she wants to give birth here, how much it's going to be for?
If she doesn't have insurance at all, I don't do much of the billing, but I want to say it's about $8,000.
And how much is the home birth?
My home birth was $4,400.
Included everything?
Yeah.
And it's not covered by the insurance?
No.
So tell me, please, what is the difference? I just try to understand, and I cannot understand. You can get the same midwife at home, and then you pay just straight from your pocket. Yeah. Or you can come to the same midwife in the birth center and be covered by insurance. Why is that?
It's the reason for the billing, the insurance given reason, is the facility. So a chunk of that $8,000 is what's called the facility fee. But it's kind of just a rigmarole. It's just...
I mean, you have the same in your bag.
Yes. There is no difference between what I carry here at the birth center as a midwife and what I carried in my home birth bag. There's just the insurance's interest in paying is different. Some sort of logistical things. The facility is what allows us to bill insurance, having a physical facility that's accredited, as opposed to birthing in someone's unaccredited home.
But you're a licensed midwife.
It's the exact, I know, my credentials have not changed whatsoever. Yeah, it's the way our system is set up, and it's not necessarily functional, and it doesn't actually serve the people in the best way possible by any means. And I think there's a lot of stereotypes about home births and home birth midwives in our country, that they just like maybe bring some magic crystals and that's it to a birth, and we certainly bring more than magic crystals. And I do think at Roots especially, we do an excellent job of being a home away from home and respecting folks' wishes, not touching people without their consent, not having bright lights, having a home-like environment. But for so many people, there's financial pressure from their family, that there's just this cultural belief that you have to go somewhere to have a baby, and it's a pathological thing that's happening. You must go be saved by a doctor or a midwife. And the birth center is a middle ground that the partner or the grandma or the whoever can agree, like, okay, we're going somewhere. We're going to a facility that has something. Even though it's truly what was in my birth bag in my trunk for years, it's the same stuff. But there's something about that. I do think that culturally, birth is so tucked away. People in the US are not seeing their aunts and their grandmas and their not their grandmas, but their moms and their sisters giving birth. We haven't grown up watching birth just happen and knowing that it's normal and pain is normal. We have a culture and a country that's focused on tucking birth away, making it sterile, removing pain, removing discomfort, not just in birth, but in anything. Pain management it's just tucked away. So a significant part of what we do as midwives is prenatal education about birth and just explaining your water is most likely not gonna break in Walmart in a huge gush, and the baby is not then gonna fall out in the car on the way to the hospital. Like, TV birth is not real birth, and it's okay to be uncomfortable. It's okay to be in pain, and it's okay if you want to bring your sister and your aunt and everyone, but they need to be comfortable seeing you in your truest, most just raw birthing self.
Let's talk about pain then, because this is really an interesting topic. Because you said that you're focused on the prenatal education for your clients to get them understand how the birth really works. But how do you manage the pain or educational stuff with the pain when you have clients who had a previous experience and not good experience in the hospitals, especially being people of color or marginalized people, and they had really bad experience and they are really fearful and they come to you. How do you work with such amount of fear of pain?
Yeah. I think for working with pain, I mean, we do a lot of education about what is normal and the purpose of pain and reframing what you think about labor pains. One thing I've heard that I'd like to pass on to clients is, and I think I'll get this right, in a 12-hour labor, a total of 2 hours of that 12 hours is spent in contraction. You can do 2 hours worth of contractions. That is okay. Or a contraction on average lasts for 90 seconds. You can do anything for 90 seconds. So just kind of framing the mental work around it, and then also teaching comfort measures, breathing, massage, so on and so forth. Getting people comfortable with movement and listening to their body. So, and I mean, in labor, like quite literally, we've got nitrous oxide, the laughing gas, and the tub and the shower and movement and massage. And that's kind of what we've got for pain management, and it works. I think people birth best when they're left uninhibited to just listen to their instincts and they have the freedom of movement. They're welcome to move around the room. They're not confined to the bed for fetal monitoring or anything like that. And then when it comes to navigating fear around medical systems or fear around pain, that gets different and more focused specifically on the individual who's presenting with that fear. But I, as a white person, can only understand so much about a community's historic fear of a medical system. I have a privilege in that sense. So acknowledging that I'm a white midwife practicing in this community, and acknowledging that I won't understand my clients' reasons for perhaps declining certain things or not wanting to access certain things, but I can respect that they are the best decision maker for their body, and I'm just here to hold the space for them to make those decisions and to provide evidence-based information and to be an advocate for them if we do need to access a hospital system, and to ensure that they're getting the best care from other providers outside of Roots if they need those providers. And that's my work as a midwife. I think sometimes that's even the more important work than just catching the babies. But how to do that kind of depends specifically on the client and what we're needing to access in the big systems.
Do you catch the babies, or do you give the mothers to catch their babies?
I encourage parents to catch their own babies, but I do frequently get that privilege of being the first to touch somebody's baby and welcome them into the world. But we do plunk them right up on their parent. We don't cut and clamp and run them away anywhere. They just go right up. But it is a magical thing to have a head born into your hands and then a whole human arrives. So I do appreciate that part of my job. Yes, we want everyone to eat in labor and eat a real meal before you go home. So we encourage people to bring a frozen meal to prenatal and just tuck it away, and then they can heat it up when it's labor time. Yeah, but this is the space for if there's extended family to wait, they can wait out here. Mostly I feel like it's staff. People don't bring a ton of extra family these days, but
Because of the COVID?
yeah. Definitely before COVID there was lots of people at births, and it's definitely tapered down, which I think is reasonable and fine. And we do discharge our clients 3 to 4 hours postpartum, assuming all is normal and well, they get to go home. And a lot happens in 3 hours. There's actually not a lot of downtime for like grandma to hold baby and stuff like that. So sometimes it's just better if family comes to their own home to visit. But they're welcome here. We call it our yoga studio. We don't actually do much yoga out here, to be honest. It's more, there was a lactation circle this morning, and we do childbirth education classes. Right now they're all virtual. They used to be out here, and hopefully someday they'll migrate back to being out here. We do all our staff meetings out here, utilize our whiteboard.
Can you tell me the difference between midwifery and obstetric models of care?
Yeah, absolutely. The obstetric model of care is led by obstetricians who are trained surgeons. They're doctors. They're excellent in high-risk things. They are knowledgeable about the most complex pregnancy pathologies. And their model of care is centered in the medical system. It is in mainstream clinics, hospitals, and that the functioning of that system is largely pushed by the insurance companies. So the timing of the visits, the frequency of the visits, and what's provided at each visit is pushed by high risk, from a high risk lens, and by insurance companies. So short visits, not a ton of time for prenatal education, not a ton of time for emotional education. Obstetricians are excellent surgeons and so useful when we need a C-section, but their model of care is focused on the high-risk population, and currently in our system, the obstetrical model is taking care of the vast majority of pregnant people, not all of whom are high risk. The midwifery model of care really centers the pregnant person at the middle of their care. They are the keeper of their baby, and they are the keeper of themselves, and they know the most about their body. So the midwifery model focuses very much on education, holistic approach, nutrition, herbs, supplements, and listening to the person who's having the baby. I think we take more time with our clients or our patients, whichever you choose to call them, and have a belief in pregnancy is a normal, natural life process for the vast majority of people. There are people who are high risk who do require cesarean births and obstetrician involvement, and we love to have those things available when we need them. But the vast majority of people in the US are having normal, low risk pregnancies and are absolutely appropriate for a low risk care provider to care for.
But just trying to imagine like a person with low risk pregnancy, trying to choose the place or model where to give to get the care, and they think like, okay, I'm a low risk pregnancy person, but still, if something happens, I want to be somewhere where NICU is nearby. Like how to change the mindset around that. Like we can understand that, right? But what should we understand about midwifery care model to trust it?
That's a great question. I usually have, I feel like this question comes up frequently when folks are trying to make a decision about where to birth. Is like, what happens if something goes wrong? And I like to give sort of, I guess this is an analogy. We're not just waiting for a giant red flag, prenatally or labor, birth, postpartum. We're not just waiting for like, I'm gonna swear, shit to hit the fan. We're looking for tiny pink flags along the way. Our job is to assess risk and ensure that we are encouraging people to be in the best place for them to be in terms of their medical and health risk. So if we have a couple little pink flags in labor, like, heart tone's not sounding great, maybe slow progress, there's a few little pink flags. We're not just gonna sit and wait for an absolute catastrophe. We'll go access care while we're still relatively healthy, and we're not practicing in a rash way. We're respecting that birth is a normal life event, and there are variations of normal. We're here for the variations of normal, but when we veer too far from normal, we go access help. And then I feel like frequently grandmas come to prenatals with their kids who have chosen a birth in the birth center, and they're like, what is this place? And who are you? And what do you have? Where's the magic crystals? And again, there are no magic crystals. Or there are, but we're not using them. Someone who loves magic crystals is gonna see this and be like, Rachel. I do like to talk to people about what we have and what our training is. We are credentialed providers. We're certified in neonatal resuscitation and CPR. We can suture, we can place IVs, we can drop we can treat hemorrhages, we can resolve shoulder dystocias, resuscitate babies, all of these things. And those three things, hemorrhage, dystocia, resuscitation, are fairly common emergencies. We manage those without leaving the birth center on a very regular basis. I can't count the number of hemorrhages I've been at. They've gone up significantly since COVID. But we manage emergencies without leaving the facility, and then folks go home at 3 to 4 hours postpartum.
It's great you're talking about this, because this is something everybody's afraid of, and the obstetricians are just putting some oil in the fire around this topic, hemorrhages.
Yes.
So happy you're here. When hemorrhage is happening inside the hospital, they're telling this stuff like, if you had been at home,
You would have died.
you would have died.
And I think folks, and perhaps as obstetricians, what they see come flying into the emergency room in terms of a terrible hemorrhage that may have happened at someone's home was an unplanned home birth without a midwife present. That's an entirely different topic. And I have in my life transferred, I keep bumping the mic, sorry, transferred folks for a hemorrhage that we've resolved at the birth center, but perhaps someone's experiencing symptoms of shock. We're going to go get some extra help at the hospital, which usually just looks like 24 hours of monitoring and some fluid replacement. And a nurse or someone has made the comment, oh, if you, like, you're so lucky you're at the hospital. I'm like, the hemorrhage is resolved. We fixed the problem. Like, we fixed the problem without you, hospital folks, involved, because it's resolved. And we're just here for some monitoring. No one died. No one almost died. We're here because we caught it, we dealt with it, and now we're just dealing with the residual effects of it. But people, we have a lot of fear around birth in our culture, which as someone who's given birth, as someone who's spoken to, I don't even know how many pregnant people in my life, I can understand. Like, it's one of the most challenging, unique, wonderful things you do with your body is grow another human. And it's big and scary. And our medical system pathologizes it to an extreme degree. But no, I mean, our medical system is not having better outcomes than the birth centers or the home birth practitioners, especially with women of color. The outcomes are worse, especially when it comes to hemorrhage. That's the leading cause of death for Black women in the first year postpartum.
Oh, really? Why? Why does it happen?
The root cause, from my understanding as a white woman, is systemic racism in our medical system. It all comes back to that. I just listened to a podcast by Lemonada Media. I'm going to forget the rest of the title of the podcast. Rebecca, who owns Roots, was on it. But talking about the disparities in maternal health care. And the root of the problem is systemic racism and Black women not being believed by medical providers. If someone says they're in pain, if they say they can't breathe, if they say they're concerned about their bleeding, etc., they're denied pain meds, they're denied treatment, they're told, oh, you're fine, go home. It's probably because high blood pressure runs amongst Black people. That's your problem. Well, see, once we open the systemic racism door, you're like, oh, there it goes.
I know.
It's the white nurses, it's the access to nursing school, it's the access to
I know.
college, and so
But
it's
a really large topic.
Yes, it's such a big topic, and it's so hard. We try to make change in it. We do push the needle and everything on. We are making change at Roots, but we are a staff of 10. We can do up to 20 births a month, and it's a big world. It's a big medical system, and we can make the difference we can make, but the greater healthcare system in the U.S. needs to look at itself under a big magnifying glass and through an anti-racist perspective in order to change these outcomes.
What do you think about obstetric violence and the rising numbers of obstetric violence in general? The reasons.
The reasons. The reasons. That's a good question. I don't know if I know the reason, because for me,
what do you think?
What do I think? Gosh. Well, for me as a provider, if we're defining obstetrical violence as like a cervical exam without consent, I would never do that as a human being. So where did that become okay in a provider's educational journey? Where did it become okay to check someone's cervix, to put your hand in someone's vagina without their consent? Like, how, in what universe do you put your hand in someone's body part without their express permission? So where did it come from? Probably systemic racism, probably the dehumanization of women.
So we've just come to the point where it's not just about racism, but about women in general?
Yeah. I mean, I can think of women of all races who have reported obstetrical violence.
Sure.
I think sexism for many, many, many years has silenced women. But I just, as a human, I would never stick my hand in someone's body part without their consent, so I don't know where it is broken.
We are not going to go without hospital at all.
No, and that's certainly not the goal.
No, it's not the goal.
No,
so
not at all.
we have to think about not just the midwifery model, but how to make an obstetrical model more human. You know, and that's what comes to my mind when I think about this. Like, what can we change to get away this obstetric violence thing, and why the numbers are rising? Just because women are reporting more, or is it really rising because the interventions are rising? And I don't know.
It's hard. Yeah, I don't know the root of that, but protocols, people feeling like they absolutely have to, like medical providers feeling like they have to have a documented cervical check at this time, and for insurance purpose, like malpractice insurance. There's all those layers that don't actually center the patient and the patient's well-being at the center of that care. Protocols, charting, malpractice insurance, the attending provider's in a bad mood and wants to know some information right now because they want to know if they can go home for dinner or not. I don't know.
I talked to one nurse midwife, one of our friends, and she worked at the hospital at the moment. And I asked her about the money stuff, and she said, loud and clear, that the one who's catching the baby is getting 70% of the charge for the birth. And when the doctors are waiting, like their shift is going, it's ending soon.
They want to catch all the babies.
They want to catch all the babies because otherwise another provider is going to get this money for the birth. And it's like, wow, women should know this.
Yes.
You know?
Yes. I'm sure you've seen it. I think there's been like those studies that show like babies, C-sections happen more often, like right before
more
dinner.
around
and
5
like,
or something when the
like
shifts are changing.
changes.
Yeah.
Exactly.
Yeah,
Like,
and women should know this.
yeah.
What if something goes wrong in the center? Yeah. What do you do?
Well, it depends on what went wrong, but let's say a concern about babies' heart tones in labor. We continue to monitor, well, anything, heart tones, postpartum hemorrhage, etc. The midwife will stay with the client throughout the entire experience that we're sort of about to talk about, but we will call 911. We go to North Memorial, it's the closest hospital to us, and we have a great relationship with them.
How far is it?
6 minutes by ambulance. The midwife will continue to provide care, whatever that situation is demanding, whether it's something with heart tones or something with bleeding or whatever. We'll continue to provide care per our protocols throughout that transfer. So EMS will arrive, emergency services will tell them exactly what's happening. We've called over to North Memorial and told them this is what's happening. We have a 20-year-old, she just had her first baby, here we come. And we go and continue to provide care in the ambulance. And once we arrive at the hospital, then we transfer care to the obstetricians there, and we stay with our client until things are resolved. Sometimes that resolution is an epidural. They're going to take a nap. We'll leave them. We'll go take a nap elsewhere. Sometimes that resolution is we push out a baby quickly. If we had a concern about heart turns, we stay and we're there with them through that. But we don't transfer care to EMS. We transfer care to obstetricians. So we whatever that particular thing that went wrong, in that case, we're managing it until we hand it off to the next care level.
So can you tell me any case, the hardest situation in your practice?
The hardest?
I mean, the most scary.
Sure.
And what was done?
Yeah, what can I say? I think I had a case that was a significant postpartum hemorrhage. That was hefty, but it was also like a really good example of the midwifery model of care working well with the obstetrical model of care, so it's a good story. I had a client who delivered conveniently during daytime hours. She had a lovely baby, and then she had some pretty hefty bleeding with her placenta, and she actually had what's very rare, but she had a cord avulsion, so her cord tore after the baby was born. That required her placenta to be removed manually, which is pretty unpleasant, but it is something midwives are trained to do. So
here in the center, you can do this.
Yes, as an emergency measure. Yes. So we did that. She continued to have some heavy bleeding, so we transferred by ambulance to the hospital to have that managed. I transferred with her. We had given her all of the correct medications to manage hemorrhage, done all the correct maneuvers, continued to do the maneuvers during the ambulance ride. And because we've been here for 8 years and we have a good relationship with North Memorial, they believe us when we call and we say, we need something. And I called and I said, I'm going to need an operating room because something is not correct here. We need more than just a standard delivery room. And we came flying into the emergency department and straight into the OR. And I think the thing with transfers that often feels big and hard and scary, whether it's, oh, we're just gonna go get an epidural or we're gonna go get a life-saving operating room. It's the way people are treated and the way that they're made to feel in their ambulance ride, by the hospital staff. And of all the clients I've talked to in the variety of transfer situations, people feel empowered and respected when they are respected, and when they're not judged for choosing an out-of-hospital birth, when they're not judged for choosing to change their mind and get pain management, and when they're not shamed for needing extra help. So I think that's the thing that I wish hospital-based providers would do, is just no comments. Just don't make comments about people's birth choices or bodies or whatever. Just provide non-judgmental care. That's where the trauma comes in, is feeling unheard, unseen, judged, shamed.
How do you manage then burnout of the midwives here? Because you have still, sometimes the transferring and you're dealing with the stories that are being resolved not the way they were expected to, and then you have on-call shifts and everything. Well, then that's something that leads to burnout.
It absolutely does. I think when I was a student, the preceptor, the midwife I was working with, she said the average burnout rate for midwives was 7 years, and I was like, ooh. Uh-oh. And I'm in year 7, so here I am.
How do you feel?
I used to be in solo home birth practice, and I am very happy to be in a group practice. And when I'm off call, I'm off call, and that's why we have 4 midwives, so people can have 1 weekend a month that they're on call. We rotate the week. You get 3 weekends with your family. So how do we manage burnout, off call time, being able to tap your colleagues? Having people to share the mental load of the practice and the emotional load, because it is emotional work. We are connected to our clients. When they have things not go as planned, we feel that. We take responsibility for it where it's ours to take responsibility for. So yeah, I think group practice makes midwifery much more sustainable, especially practicing in a population, the population that we practice in and the volume that we practice in. This wouldn't be sustainable as a 1 or a 2 midwife team. So.
What is your favorite way to get rest?
Oof. Well, I have an almost 2-year-old, so I don't know that I get enough rest. My favorite way to get rest.
So that you are fresh and you're committed completely to the woman when you're on call.
Oh gosh, I am a bit of a workaholic, so this is a great question. I used to crochet, but it's been a minute. What do I do for rest? I really enjoy outside time and gardening. I have a lovely community garden plot. The garden, last summer, she was smaller then. We would just take the stroller and the dog and walk to the community garden plot every evening and garden, and that was great. So I think outside time and kind of connecting with nature makes a big difference for me. And puppy snuggles. And that's my baby.
Oh, that's your baby. Have you changed as a midwife after having your own baby?
I have. And I still maintain that you can be an excellent birth worker prior to giving birth. But I think that my understanding of what pushing a baby out has understandably changed. And I think it's just, I don't know. My priorities have changed. She's more important than anything. And I also understand that for my clients, the baby they're birthing is more important than anything. And they need me as their midwife to show up with that understanding that that's what they're doing. They're birthing their little human. I did that. I had people hold space for me to do that, so I will hold the space for them to do that. I mean, I think one thing that Rebecca always says about Roots, actually, something I have written above my desk that you can take a picture of if you want. That is a combination of a Rebecca quote and a Robin Wall Kim quote. No, not Robin Lim. Robin Kimmer Wall. Shoot, I'll send it to you. But it says, seek upstream solutions, remembering someone is always downstream. And Rebecca said that she's seeking upstream solutions to the maternity care problem in the world, meaning it's not just standing downstream catching people. We're going upstream to figure out why people are falling in the first place. And then the book Braiding Sweetgrass by Robin somebody, said, remember someone is always downstream. And that's the only book I managed to read completely when I was pregnant. Do you want to nurse? You can nurse in a minute. And she said in it, remember someone is always downstream. So the actions that we do, or what we do, has an impact for the long term. So that's kind of just how I've tried to approach my work at Roots, of seek the upstream solution and remember its impact. Right?
It's just beautiful.
Seek the upstream solutions, remembering it's a microphone. Someone is always downstream. You can say something. What do you think? Do you remember being born? Oh gosh. I think the thing that is difficult is being both a mother and a midwife. I'm the primary income in my family. My partner's home full time with our daughter. That is difficult. I think meeting the demands of motherhood and capitalism is what's hard. She's an easy baby. She's lovely. She nurses, she sleeps, she snuggles, she says many words. She has big opinions. She's gonna be a little mover, shaker baby. But leaving her in the night to go meet other people's babies, that's the hard part, I think. So.
Do you miss her?
I do miss her, and I think it's just confusing for her. At this point, if I say, Mom has to go to work, she goes, oh, mama, baby, belly, vulva. And I go, oh, yeah, that's what I'm gonna go help someone do, have a baby come out of their vulva.